Hey, Herbert, try and be interesting. Isn't that great? Yeah.
That is funny when I say it, but not when you say it. Okay, let's do the general treatment of MI. So, first of all, the most important thing, well, one of the most important things you can do for a patient having acute myocardial infarction is get the defibrillator ready, ladies and gentlemen. As I said earlier, 30% reduction in death just from, actually it was more than that, it was like a 50% overall reduction in death just from the early use of defibrillation. The concept was the heart too good to die. You have a good heart, like Aaron's.
I do.
Gets some ischemia, gets a VFib,
Yeah.
and he dies. If you get the defibrillator there early, though, boom, he's back, he lives forever. So defibrillation is good. That's why you put the defibrillator on it. Aspirin. Aspirin is also good. Significant reduction in death, in stroke, in recurrent infarction. So everybody without a contraindication obviously gets aspirin. That is a no-brainer. Nitrates. We don't really know if nitrates reduce mortality, but they reduce pain, they increase blood flow. Maybe they reduce mortality a bit, so we'd use nitrates in just about everybody. Beta blockers for the exams have come and have gone. So it used to be if you didn't give beta blocker to a person with an MI, you failed. And then about 5-10 years ago, we have had this big turn away from beta blockers because of the big Chinese study that said it doesn't work. So on the exams right now, only give beta blockers PO and if they're really hypertensive and really tachycardic. If there's any CHF or giving them IV is kind of out right now for the exams. ACE inhibitors work, but not usually within the time frame of the emergency physician. You need to give ACE inhibitors, but just in the first 24 hours, right?
Got it.
The indications for thrombolysis. Now, this is really important. You need to know this. Aaron, you need to know this. Paul, you're not a doctor, but you even need to know this.
Yeah.
Because it's that important.
That's how important it is, Paul.
The indications for thrombolysis is you have to have ST segment elevation. It just turns out that no ST segment elevation, thrombolytics don't work, except in that one case that we've said 100 times, and it is
Posterior MI.
posterior MI, where you have ST segment depression in the anterior lids. So you have to have ST segment elevation. Most of the guidelines, the simple way of remembering how much ST segment elevation is just 1 millimeter in 2 anatomically contiguous leads. There is some difference between the guidelines, but the simple way to remember is 1 millimeter in 2 anatomically contiguous leads in somebody you think is having an MI is an indication for thrombolytics. You have to have chest pain for more than 30 minutes, but less than 12 hours. If it's less than 30 minutes, then maybe you can abort and they're not having an MI. More than 12 hours, there's probably no benefit. Some of the guidelines say 6 hours, but it really depends on where your MI is.
That can get a little complicated in the real world because people have stuttering chest pain and all that kind of nonsense. So you're like, 12 hours? I don't know, 14 minutes?
Right. In the exams, so they'll make it easy.
They will.
No PCI available, and what this means is that we all kind of accept now that if you can get to PCI pretty quickly, it's better than thrombolytics, mostly for the reduction in intracranial hemorrhage risk, and maybe some benefit to the heart as well. But that time frame is all over the place again, but 90 minutes is the real cutoff. I can thrombolyze you now versus I can PCI you in 60 minutes, choose the PCI. I can PCI you in 3 hours, too long, thrombolyze now.
Yep.
You got to make sure they have no contraindications, no absolute contraindications. And one of the things that comes up all the time is this left bundle branch block thing.
Yeah.
If you've got a known new left bundle branch block, that is considered an indication for thrombolysis. How do you know that? I saw Aaron yesterday.
Yeah.
I did an EKG.
Yeah.
He had no left bundle branch block.
Wow.
He now presents with chest pain. I do another 12 lead today, and he has a left bundle branch block.
That's how you know.
New.
What if you're presumed new?
Presumed new is the one that gets very confusing, and I don't think the subtleties of that they're going to worry about in the exam. Okay. All right? So, ST segment elevation, 1 millimeter in 2 anatomically contiguous leads, new left bundle branch block, or left bundle branch block with Scarboza criteria. Now, for a long time, the exams didn't have this, but there's been so many studies on this now that shows that this actually works, that we should talk about the Scarboza criteria.
Yep.
All right? Not for ST segment depression, as we talked about. So, I'm going to play a little animation here. Are you ready, Paul? Do you have the audio from the computer?
From the computer where the audio comes?
Where the computer and the audio and
the
the
digital
music.
audio, that audio, digital, it's zeros and ones
Do
usually.
a quick animation of Scarboza
Usually digitally.
criteria. Bam! So let's do a really quick and dirty of Scarboza. So, in a normal QRS complex, in a left bundle branch block, the J point, which is here, that's that change in direction of the QRS, should be on the opposite side of the baseline, should be down here. This one is on the same side, so that's bad. Scarboza says also, even if it's on the opposite direction, so here's the terminal portion of the QRS, here's, say, your J point's about here, it's on the opposite side of the baseline, that's fine, But if it's too much, if it's more than 5 millimeters on the opposite side, that's too much of a good thing, and that's bad. And so here's another example. The terminal portion of the cuirass is down. The J point is also down below that baseline. So that's also bad. So that's the quick and dirty of scarbosa. Again, you can look at some of the EKG segments to get it in more detail. But that's the key thing.
Yeah.
So did you get that scarbosa stuff?
Did.
You understand it?
Check. Understood.
Done. Now, again, I got to be honest with you. I don't know if they're going to ask specifically about that in the exam, but I think you should know those concepts because they are important clinically. And it is reasonably examinable at this point.
Yeah.
It's been studied multiple times.
Right.
Now, you need to know the contraindications to thrombolysis. Now, in the real world, Aaron, when somebody comes in and they're having an MI, do you have a checklist to determine whether they're eligible or not?
I do, and I keep it on my person.
Yeah, well, you're not allowed to bring that into the exam.
You're
so
not?
they'll often ask you some of these. I'm going to list these out, then I'm going to show you a simplified way of thinking about this. I don't think you have to worry about all the relative contraindications, but you should know the big absolute contraindications. And they are, obviously, if you're actively bleeding right now with a bleeding disorder, probably shouldn't give thrombolytics. You're having a bad day if you're having an MI and you're bleeding out. If you've had an ischemic stroke in the last 6 months, if you've had a cerebral hemorrhage at any time, you can't get thrombolytics. If you've had a closed head injury in the prior 3 months, and they don't really define what that is, but any significant whack on the head in the last 3 months is a contraindication. If you've had major surgery in the last few months, bad because you're likely to bleed. If you've got an intracerebral tumor or an AV malformation, that's bad. You're increase your chance of bleeding into your head. If you have uncontrolled, and this is the key one, uncontrolled systolic pressure over 180 or diastolic over 110, this should actually never be a contraindication in reality because you have more drugs than they have blood pressure. So this is, they came in a systolic of 200 and you couldn't get it down. You shouldn't give them thrombolytics because they bleed in their head. But you can give them drugs to get it down. So focus on these absolute contraindications. So another way to think about that is if there's badness in their head, so they've got a prior intracranial bleed, they've got an AVM, they've got an intracranial neoplasm, they've had a stroke in the last few months, they've had a head injury, anything bad in their head is most of these contraindications. And then there's other things like, you know, they've got active bleeding or they've got a dissection, for example. That wouldn't be a good idea. Relative question, go.
Can you go back to your 2 slides? Because you put 6 months on the first one and 3 months on the second one, I think.
For what? Stroke?
Yeah.
Oh, yeah. So actually, that's a good point. So I did do that. There is a mistake there, except that it's not a mistake. And the reason I say it's not a mistake is that I had open Tintinelli, Harwood Nuss, Rosen, and a number of other sources on the internet. They're all different.
Yeah.
So it's going to be very hard for them to do a too tightly asked question on this because all of the references are different. So know the general concept of strokes, bangs on the head. But they can't ask you the exact time frame because every single book has a different time frame.
All this stuff is changing too, just as an aside for strokes. Stroke thrombolytics is changing right in front of our eyes. So you can't really put those in the same category in your brainiac.
Some of those guys. So one of the guideline things says thrombolytic therapy is contraindicated for stroke more than 4.5 hours and less than 6 months.
That's right.
Oh my gosh. So again, the concepts are important. The exact time frames, I don't think you need to memorize. So good pickup, Aaron. Nice. You were listening.
I do what I have to do over here.
Lots of relative contraindications, and you can sort of guess these. So if you've got current anticoagulation use, maybe you shouldn't do it. But it turns out, of course, that there's lots of these thrombolytic protocols where we anticoagulate you. So it's not a big one. Prolonged CPR is not an absolute contraindication. Prolonged CPR where you broke 4 ribs and grandma's already bleeding is bad. Pregnancy. If you're having an MI and you're pregnant, I'm sorry.
I'm so sorry. Yeah, I'm so sorry.
So these are not absolute contraindications, and you have to weigh up the risks and the benefits. All right? So let's continue on.
Let's.
What are the complications of thrombolytic therapy? The single biggest complication of thrombolytic therapy we're all worried about is intracranial bleeding. If you bleed, if I give you a thrombolytic therapy and you bleed into your head, you have a 50% mortality, and that's probably the lucky 50%. Because the other 50% are often gravely disabled.
Right.
The risk is about 1 in 50 to 1 in 100, and maybe higher and maybe lower, but it all depends on your risk factors. So the risk factors make you more likely to bleed in your head as you're older, you've got hypertension, they've used TPA, you're female, you're black, more hypertension, low BMI, and there are some others. So what happens is if you add these things up, your risk of intracranial bleeding goes up and up and up. So if you're an old black female that's very skinny with hypertension and they're about to use TPA, you can actually get the bleed rate down to 1 in 40 or less.
It's terrible.
So that's why you need to add up these risk factors.
Have you seen
and
this
decide.
personally?
Have I seen what?
The intracranial bleed from after thrombolytics?
The first 3 patients I gave thrombolytic therapy to in the early 90s bled into their head.
Yeah, I've seen it too.
Oopsie. Major bleeding occurs about 1 in 20, about 5% of patients. So that big GI bleed or something, that we don't worry as much about. We can control it. Allergy is a problem with streptokinase, although there's very little streptokinase used except at ABEM general. TPA, you don't have as much problem. And then if you bleed into your head in particular, then it's, you've got to try everything. You give them blood, you give them FFP, you give them cryoprecipitate, you give them aminocaproic acid, you call the neurosurgeon. It's a 4-alarm fire trying to reverse this thrombolytic, and it doesn't work particularly well. So you just don't want to bleed into your head. That's why contraindications to thrombolysis are important, and these risk factors for intracranial bleeding. It may be that the risk of bleeding into your head is much higher than the benefit that you're going to get from the drug. Again, on the exams, that's a little too sophisticated for the exams, but understand the concepts. So here's an example questionnaire. Let's see if we can get this puppy.
Yep.
And again, these are not real questions. These are just sort of reminder questions. 52-year-old, chest pain, 4 hours, short of breath, sweaty. EKG 1 week ago showed it was normal. This is a pretty normal looking EKG.
Looks good. Looking good.
Today,
holy mother of left bundle branch block.
Holy mother of left bundle branch block. So it's wide, it's left bundle. And so what is the therapy here? Do you give aspirin alone? Well, you can give aspirin, sure, that's a good thing. Yeah. Do you give high dose beta blockers to MI patients?
No.
Not anymore. No therapy? What is this, 1932?
What are we, savages?
Thrombolysis if no contraindications?
Okay.
That's a reasonable thing to do. So again, not a very well-worded question, but brings up the important thing. Everybody gets aspirin. Don't give beta blockers to all of these people. Certainly high-dose IV. You are going to give them some therapy. And in this case, if it was a new left bundle, that's an indication for thrombolytics in most of the guidelines.
Hey, do you see any scarbosa in there, just while we're looking?
Scarbosa. So the terminal portion is down and the ST segment is up. Right. Terminal portion is down, the ST segment is up. And it's not really up, so I don't see any scarbosa criteria here. The terminal portion is down and the ST segment is down, is on the opposite direction. So I don't see, and you actually go through every single lead and you look for whether there is scarbosa criteria. I don't find any scarbosa, but it's a new left bundle, which might be alone. At some point, the guidelines are probably going to change to forget new left bundle branch block and just use scarbosa. We'll let you know when that happens. I'll send you an email personally.
We'll call you.
So then the next thing you need to know is, I know about thrombolytics, and I know who not to give them to, and I know the complications. Now I have to ask the question, did it work? So this is something that they could certainly ask you questions about. So I'm given the thrombolytics. How do I know it works? First of all, your pain goes away. Went from a 10 out of 10 to a 1. That's a good sign. ST segments have gone down. In a lot of the textbooks, they talk about a 70% reduction. So a big lowering of their ST segment suggests they're reperfused. If they develop a reperfusion arrhythmia, that's a good sign. The classic one that is on exams, you won't see it very often, but the classic one, it's accelerated idioventricular rhythm, which is essentially slow VTach. It's wide, it's around 80 or 90, it's a perfusing rhythm. You don't want to suppress it. You don't want to give them lidocaine or amiodarone or something to try and suppress it because it's a perfusing rhythm. And that usually doesn't come up because this is usually very short duration. It's less than a minute. You look up at the monitor as their pain's getting better and their ST segments are coming down, and then they have this run of looks like slow VTach. Don't freak out. That's another good sign that they've reperfused, and it usually only happens once or twice.
I always think about that as, since it says accelerated interventricular, the ventricular rhythm would be what, 40?
40.
So accelerated means a little faster than the ventricle should go. So accelerated idioventricular.
Excellent. So don't suppress it. Leave it alone. It'll get better.
Don't suppress me.
Just make sure it's not VTach, though, because these people could also be having VTach.
They're
dropping their blood pressure and they got VTach. You defibrillate them. But if they're hemodynamically stable, this is actually a good sign. So what are the indications for percutaneous interventions? Here, they're basically identical to thrombolytics. That's the simple way to think about it. So if you've got a STEMI greater than 30 minutes, less than 12 hours, that's an indication. There's a couple of extra ones. If you've got STEMI plus shock, it's probably better to go to PCI than to give them thrombolytics. If you've got STEMI plus a contraindication to thrombolytics, obviously that would make sense. If you gave thrombolytics and they failed, I'm having a big angioMI, I gave you the thrombolytics, Aaron.
Right.
Your SD segments didn't come down. You still had pain.
I'm a failure.
You're a failure. My thrombolytics didn't work. Then send this person to PCI.
Just like my mom said.
Now, the nuances to when you do PCI versus thrombolytics and the time frames and all this stuff is very complicated, changing constantly. The exams will generally stay away from these nuances because they do change frequently. Concentrate on these puppies right here and that magic 90-minute time frame.
Yeah.
Thrombolysis I can do right now, or I can wait and do PCI. Don't wait more than 90 minutes
Door to
the balloon blowing up.
Door to balloon, 90 minutes. It's weird, right? Because you never know when the damn thing started. So like, but for some reason we decide when they walk in the door, we start the timer and it has to be 90 minutes.
Right. And that's why it's so variable, because if your MI started 6 hours ago, you got way more time. If it started 30 minutes ago, it's different. So that's why exams are too hard to do the nuance of that. So here's another example question. You ready?
I'm ready.
Paul, you ready?
Bring it.
Paul is ready. 52-year-old presents with, it's always a 52-year-old.
Yeah, what is that?
I don't know what my deal is.
I'll tell you what that is. That's lazy Mel Herbert making up 52-year-old people with diabetes.
I'm killing off all the 52-year-olds. 2 hours of chest pain. With this EKG, vitals are stable, has a history of an intracerebral bleed 3 years ago, though. 3 years ago.
Oh, only 3 years ago?
What therapy do you give? Do you give aspirin?
Nah.
Yeah, you do.
All right.
Aspirin you can give.
Oh, not alone?
Well, that's true, not alone.
That's your first question. Listen,
sorry,
I'm trying to. Could you pay attention to your own?
Thank you.
I swear.
Aspirin plus PCI.
Okay.
That sounds reasonable. Aspirin plus TPA. No, because he's had an intracranial bleed. No TPA.
Correct.
Aspirin plus half dose TPA. No, not a half dose, not a full dose. So the right answer here is aspirin plus PCI. So again, it won't be worded exactly like this, but the concept is there is an absolute contraindication. Don't give the thrombolytic. Give them something else.
Easy question.
And PCI is the likely answer. And I threw in aspirin alone and then confused myself. Aspirin is good, but you probably should do more than aspirin.
No.
Because this person, I didn't even talk about the EKG. The EKG shows he's got a big anterior, septal.
That's right.
And even some extension out laterally. It's a big MI.
Yeah.
Aspirin is not enough. All right. Who here likes to do cocaine?
No, right here. I mean, wait. Is this being recorded?
Is this,
are we alive?
Is this live? Is
this not going to go out to anybody, is it?
No.
I'm going to mute it for a minute.
Okay. Yeah. Thank God.
Cocaine, chest pain.
Cocaine, chest pain.
When somebody does cocaine, they often get chest pain. They get chest pain for a number of different reasons. The one that we worry about in particular is acute coronary syndromes. You snuffleupagus.
Do you snuffle it, really?
You snuffle or you
I can see you're totally experienced that you can snuffle it.
You get the cocaine and you shoot.
Got a problem snuffling cocaine.
And then you get vasospasm. That vasospasm can actually produce MIs.
Yeah.
But most of the time it's just vasospastic. These patients are actually fairly low risk. They're generally younger than the average MI patient. And they generally do pretty well. If you do a few EKGs and they're normal, if their tropes are negative, these patients can generally go home. If they're having an ST segment elevation that doesn't come down, then you treat them. We don't know for sure, but we just treat them like a normal MI.
Yep.
But the real treatment for an acute coronary syndrome for ST segment elevation MI or a non-ST segment elevation MI in the face of acute cocaine is benzos, calcium channel blockers to reduce for some of that spasm, phentolamine, which is that pure alpha blocker if they're really hypertensive. And then if you do all that and their ST segments still stay up, they actually may have blown a plaque, then you can consider thrombolytics. But remember, when they have chest pain, it could be from acute coronary syndrome, it can be from a pneumothorax, it can be from a pneumomediastinum, and in a whole bunch of cases, we don't know what it's from.
Are you telling me that if I take cocaine and I have an ST elevation EKG that I'm not going to go right to thrombolytics, I'm going to go to benzos first?
Yeah. Okay. You go aspirin, benzos, nitrates, and maybe phentolamine if they're really hypertensive. And if their ST segments come all the way back to the baseline,
then you can call it a day.
Then you can probably say, okay, mid ICU, watch. It's probably mostly spasm.
Okay, good. Thank you.
If they don't come back to baseline, then you consider thrombolysis or go into the cath lab.
All right.
And remember these other causes of chest pain, particularly those people who are taking their cocaine or whatever drug and they're putting it into a volatile form and doing this and sucking it in, they can get pneumothoraces and pneumomediastinoms.